Welcome back. Today we'll be going through the pericardium. So the pericardium is made out of a fibrous serous material, and it encloses the heart and the roots of the great vessel. It lies in the mediastinum between the second and the sixth costal cartilages, and it's attached to them via these strong ligaments. Here it's attached to the superior sternum and the inferior sternum, along with the vertebra of the neck. And it prevents the excessive heart movements by just restricting the turning of the heart, because once the heart contracts, it squeezes in like a twisting motion. So these prevent excessive twisting. And it's also strongly attached to the diaphragm via the phreno-pericardial ligament. So when you take a breath, it actually pulls the heart downwards. And then the pericardium will fuse with the outer coats of the great blood vessels, which are the superior vena cava and the aorta. The serous pericardium is made out of two layers. The parietal layer is going to be on the inside, it lines the fibrous pericardium, and on the outside is the visceral layer, and that's made out of myocardium. Inside is the pericardial cavity filled with pericardial fluid, which is made out of like lipids and glycoproteins in order to make it viscous and prevent friction. There's about only 50 milliliters inside. Sinuses are the recesses of the heart, and the oblique sinus is the reflection of the serous pericardium around the pulmonary vein. So it's on the posterior side of the heart, next to the left atrium, as you can see here. And then the transverse sinus is going to be in front of the superior vena cava on the posterior surface of the heart. And then there's such thing as a bare area, and that just means that there are no pleura due to the notches. So here's going to be the transverse sinus right here. It goes right across. And then this is the reflection. Here's the oblique sinus. And then here, the transverse sinus really just goes around. The cardiophrenic and muscular phrenic artery supplies the pericardium, and those come from the internal thoracic artery. There's a variety of branches that come from it too. And the coronary artery supplies the visceral layer, and the veins that accompany all of these arteries, they drain into the azygous and the hemiazygous vein. And the fibrous pericardium and the parietal layer of the serous pericardium are innervated by the phrenic nerves. And there's a bunch of them, really, like all the branches. The visceral layer is innervated by sympathetic trunks and the vagi nerve. So pericarditis is the inflammation of the pericardium, and is usually caused by rheumatic heart fever, actually. That's something really concerning in children in particular, because it causes like atrial fibrillation and heart murmurs later on, even after the child has recovered from rheumatic heart fever. So in those cases of infection, the pericardium is going to be inflamed, and there is friction due to the layers rubbing against each other and the heart rubbing on the layer. So the friction happens, and then the pericardium is irritated. So it's inflamed, and it can compress the heart, and that's what causes the heart rub, and you can hear it on auscultation. So it can also be caused by cancer of the pericardium, or trauma, or surgery complication. And a pneumopericardium is like air caught in the pericardium instead of hemopericardium, which is blood caught in between the pericardium layers. and that is also caused by like trauma, infection, along with drainage complication. So the veins aren't able to clear the old blood from the pericardium. As you can see here, it's really characterized by like a flask shape. So here's like the thin, like a top thin, narrow neck, and then it gets a lot wider. Here's the heart, and here is the pericardium. See, concern. And when you listen, there's going to be something characterized as a mill wheel murmur. Cardiac tamponade is a life-threatening condition where there's too much fluid and then the pericardium is incredibly enlarged. Like, this is a normal heart. This is somebody with cardiac tamponade. And it's the water bottle sign. As you can see here, there's going to be like the round bottle and then the flask, or the neck. They call it a water bottle. I like to call it a flask because it really looks more like a flask. And it compresses the heart and like restricts the movement by a lot. And it's caused by viral bacteria, pneumopericardium, and that also occurs mostly in infants. And when you check the amount of blood, so remember, or not blood, pericardial fluid, remember before I said that a normal amount is about 50 milliliters. In somebody with a cardiac tamponade, it's about 300 milliliters. So in these cases, you have to have emergent pericardiocentesis or a pericardial window done, which is able to drain the fluid from the pericardial sac. And then when you do an ECG, it shows up as something called an electrical alternans. You really should memorize this. It's going to come in handy later on when you're studying, like, the QRS and T amplitudes of the ECG. As you can see here, these all should be about level, and they all should be like regular intervals. But with the alternans, as you can see, it alternates. Like, there's all these, and then all of a sudden it's a lot smaller. All of these normal, and then all of a sudden gone, and then back to normal. So pericardiocentesis is done when the patient is semi-reclined, and then a big needle is used. So in an anterior approach, you go above like rib 5, but the most common is to enter the under the xiphoid on the right side between. You want to enter right under the xiphoid between the left costal margin. So you enter through the left side to drain the heart, and the needle is introduced as a 45-degree angle. Usually it's done under the xiphoid, but if somebody is morbidly obese, they have to go through the rib 5 anterior approach. So the heart surfaces, here's the top. It's borders with the atrium, right atrium, and the ventricle, and then the inferior diaphragmatic is going to be the right and left ventricles, along with a little bit of the inferior right atrium. Pulmonic is going to be the left ventricle and the right atrium. And then the posterior base is going to be the left atrium, while the apex is directed down, but forwards and a bit to the left. This is important to know just because, like, you have to keep in mind that the heart is a 3D structure, not like a 2D structure. So it kind of like sits and projects. So here are the borders of the heart, bordered by the upper border is bordered by the atria. The right is like sort of vertical and is formed mostly by the right of atrium. Inferior border is going to be horizontal, then is mostly the right ventricle. Left is going to be left auricle and the left atrium. Inferior is going to be the right ventricle and some of the right atrium. Like I said before, just remember it sits and projects, so you have to know that it's 3D. The walls are made of myocardium, which is covered by the serosa, or the epicardium, and inside is the endothelium, or the endocardium in this particular case. So the atrium inside the auricle is rough. It's trabeculated. It just means it has all these roughened branches. And the inside of the auricle is rough, while the outside is made of smooth muscle. And between the right atrium and the auricle is the sulcus terminalis, and those make the trabeculae and connects the crista terminalis to the auricle. And then the superior vena cava, inferior vena cava, and coronary sinus all drain into the right atrium, and the internal or the inferior vena cava and the coronary sinus doesn't have any valves, and the right atrioventricular orifice lies anterior to the inferior vena cava opening, and that is guarded by the tricuspid valve. So here are the trabeculae. Here is your valve. It's also known as the thespian valve of the coronary sinus. And over here is going to be the valve, or the Eustachian valve of the inferior vena cava. It's really important to know that this is different from the Eustachian tubes in the ear. Here's your fossa ovalis, is usually sealed, and here's the septum. Here is a cadaver image. Alrighty. So the right ventricle communicates with the right atrium through the atrioventricular orifice and with the pulmonary trunk. So the pulmonary veins will connect to the right ventricle. Between the pulmonary auricle is going to be the infundibulum, or the conus arteriosus, and that one is also rough with the trabecula carne. The trabecula carne is made of the papillary muscles, so like they're attached to these like little nubs, and the moderator band extends from the intraventricular septa to the papillary nerves or muscles to convey right bundle branch, so it conveys the nerves. Let's see, this is the right ventricle. It's a lot like smaller actually than the left ventricle, and then it's guarded here by the tricuspid valve. The papillary muscles are going to be attached to the cusps, so like projections of the tricuspid valve. Here you go. Here's your papillary, and here are the chordae. And the second type of papillary muscle is going to be attached to the ventricular wall on one end, but the other ends are free. And then the moderator band will connect the anterior papillary muscle to the anterior wall, and that conveys the right bundle branches. And then the third type of papillary muscle is just a bunch of ridges. So the tricuspid valves, there's 3 leaves, and they're the anterior, inferior, and septal cusp, and they're all attached to the fibrous skeleton of the heart, and the chordae tendineae. So the chordae will prevent the prolapse of the tricuspid, and it works because systole will push the blood through the valve and open it, but the chordae will like slam it shut. The pulmonary valve have 3 semilunar valve, and that's going to be the anterior, the left, and the right, and they're also curved, and those are also attached to the fibrous skeleton along with the arterial walls. And then the root of the pulmonary trunk has 3 sinuses, and those are situated external to each cusp. So in between the cusp is also known as like the commissure. Coronary sinus is like right beside it. The left atrium is the main cavity, and the left auricle is both are going to be roughened with like trabeculae, like right here, and it touches the esophagus. So now if you have like acid reflux, it feels like it's coming from the heart. It's not. It's from your esophagus, and it has 4 openings, 2 for the pulmonic veins from each lung, and it's guarded by the mitral or the bicuspid valve. The left ventricle is going to be the largest and most muscular part of the heart because it needs to push all the oxygenated blood to the rest of the body. And it's if you look like in a coronal view, so top going down, you can see that the left ventricle is going to be round while the right is more of an crescent shape. It also has the trabeculated muscle along with papillary muscles. And then it's connected to the aortic vestibule, which leads into the aorta. And then the mitral valve will lie between the atrioventricular and aortic orifices. The wall is thicker, as I said before. And the aortic sinuses are going to be the right and left coronary arteries. So the septa divide the heart, and they will be very muscular, but a small part of it is membranous. So the skeleton of the heart is made out of cartilage, fibrous rings, and they surround all of the orifices. It's continuous with the membranous upper part of the ventricular septum, and it prevents stretching of the valve where the leaflets attach. And as you can see here, the ventricle muscles are more like kind of like oblique, while the aortic muscles are more like not longitudinal, but like horizontal. The conduction of the cells are done by the pacemaker cells, and those stay in the sinoatrial nodes and the upper sulcus terminalis, and from there it goes to the AV nodes, and that's the AV bundle of His that will go to the right and left branches, and the AV node serves to pause the conduction so that the right atrium is able to empty completely. So it goes down into the right bundle branch, which passed down the right ventricular septum to reach the moderator branch, and then from there it's conveyed and becomes the Purkinje fibers. The left, on the other hand, will pierce the septum and then do the same thing. And the anterior nodal path will go from the sinoatrial node through the arterial septum to the AV node, or the Bachmann's bundle to the left atria, and that serves to coordinate the atria to contract at the same time. So let's go through this path one more time. The middle internodal path goes behind the superior vena cava through the Bachmann's bundle to the other atria, or to the left atria. And then the posterior internodal path will go from the sinoatrial node descending through the crista terminalis and the valve of the internal vena cava to the atrioventricular node. And then the node goes to the bundle of His, and then the bundle branches, and then the Purkinje fibers. And all of this serves so the heart can contract in sync. There's a lot of problems when the conduction of the heart is off and the heart can't contract. So it contracts from the apex up, of course, squeezing, like squeezing toothpaste from the bottom up. Commotio cordis is a condition that is caused by blunt trauma to the chest, usually it's sports related. When somebody throws a curveball, a kid's not paying attention, gets smashed into the chest. Problem is, ventricular fibrillation, so a problem with conduction, can occur if the blow just happens to hit at the upstroke, and then you see the ECG and it goes crazy. In most cases it goes away, but in severe cases it results in like sudden death. Okay, that's it for now. Thank you for your attention and good luck studying.